all work is half done if women are not involved, said Mahatma Gandhi. To involve in making of world, we want our girls to dream, and we want one day their dreams to be realized so that they can lead a life of purpose and meaning. To empower our girls, three major requirements are there. One, educational institutions. Two, healthcare institutes. Number three, community development organization. Let's come to the second point, healthcare. Though in recent years, there has been a good efforts in terms of infrastructure. According to National Family Health Survey, the health profile of Northeast, especially Assam, shows that 36% children, they don't get adequate height and weight. 32.9% children below the age of 5 years, they are underweight. Maternal mortality rate, MMR, is highest among states. So how to lower these numbers? How to address this malnutrition? So this session's topic is women health, malnutrition, and healthcare in Northeast. To participate, Mrinal already introduced our panelists. They are all our experienced. Dr. Monisha Behel, she is a social activist, founder, Northeast Network, আৰু বেনবাৰ আৰু এটা পৰিচয় আছে যে তেওঁ আমাৰ আপোন জ্যোতিপ্ৰসাদ আগৰৱালাৰ ভতিজা জীয়ৰী, হৃদয়ানন্দ আগৰৱালাৰ জীয়ৰী. And another one, the UNICEF state head, Dr. Madhulika Janathan, she is very experienced. Chairman, Pratiksha Hospital, Dr. Pramod Sharma, experienced physician, and he has done tremendous on these issues like healthcare. So my first question, that is opening remarks, will be to all of you. Should start from Benba, Dr. Monisha Behel. So how, where do you find the stereotypical gender challenges in regards to malnutrition amongst women of Northeast?
Thank you. Firstly, I'm very privileged to be here. Especially there are lots of young people, and I think I met some of them from the Assam Association. Aru amar, what's his name? GP Singh, no? GP Singh e koar nisna tekhete je koisile olop mentor koribo lage ketaman lora swalik tumalukor logot. I think that's a very good idea because we have been doing that since 1978. I've been at least doing that. So your question was about the gender challenges. Pratham kotha hol amar society, whether it's Nagaland, Assam, or even Meghalaya, it's very patriarchal. Eta sobe mur logot torko kore je Meghalaya nisna eta jaga is they practice matrilineal because the woman gets the land. But if we look at the statistics of abuse of women, because we also run centers like that, it's very, very high. And because of patriarchy, the two things that we have seen is swalibure ekkebare pisot khai. Jodi bhayak aru bhoniyak ase, bhayak tu agote khabo, tasot swali jonie oin kiba koribo. Jodi bhayak tu ulai jai rati, kuno question nokore, swali jodi jai, teta khudhe to kot goisili. So these are the elements of patriarchy, and therefore I think we have to get rid of some of these things, and we can explain more later.
Thank you, Dr. Monisha Behel. Now coming to Dr. Madhulika Janathan. The same question, your opening remarks and opinion on that.
So when we talk about women and healthcare, you also spoke about maternal mortality, which is really the rate of women dying per 100,000 live births. And as a country, we've actually done better. We've improved, and the maternal mortality rate, the rate of women dying due to childbirth, has reduced from 113 to 103. And Assam has also done well because those rates have also come down from 328 per 100,000 live births to about 205. One area that remains to be, I would say, explored really is the data challenges in the Northeast, and to understand how we could actually get more numbers for the other 7 Northeast states where we actually have absolute numbers. Having said that, maternal mortality and maternal health, so let's come to health and let's not go to the point of death so that we actually save them. When we talk about maternal health and women's health, and specifically during the time when they are expecting a baby, bringing new life, it is really a point of women's rights as well. It's the right to life, herself and her child. And one thing that, that I really want to speak about is access to care, where we are going to talk about, where we want to talk about the continuum of care from adolescence, because a woman cannot become healthy just at the point she's going to have a baby. She has to be healthy before she has her baby. So that is a point when we're talking of adolescence, where we want to invest in adolescent health. And we know that adolescent anemia is one of the big challenges for us in the Northeast and in the country as well, where we want the adolescents to have a better health and that investment in adolescent health. Speaking a little bit about the work in the tea gardens, where we work with about 205 tea gardens, and we work with adolescent girls. So when we talk about maternal health and adolescent health, very multidimensional. It means that the girl has to be in school, that she needs to access healthcare at the Anganwadi center. She needs to not be married before she attains the legal age of marriage. And so the whole issue of maternal health then not only becomes multidimensional, it's also intergenerational. So as a girl, if I'm married before I'm legally supposed to be married, my body is not ready to have a baby. So it's a teenage pregnancy, which is the highest risk when we talk about high-risk pregnancies. And also bringing attention to the fact that the baby I will give birth to will be low birth weight. And it will create an intergenerational malnutrition because the baby is already very small and will struggle to survive. So beyond all those issues of healthcare, access to education, access to even social protection schemes, which we can discuss later, just to set the context, taking from the point that Monisha Behel made, that it is also a lot of gender inequality. The access that women have to these services. As a girl, do I go to school or does my brother go to school? As a girl, do I go to because it's too far away to cycle, will I drop out in class 8 and never see class 10? I think these are the existential questions that we need to look at.
Thank you, Madhulika. Now, Dr. Pramod Sharma, your opening remarks and that stereotypical gender challenges.
Thank you so much for allowing me to participate in this discussion. See, now if we talk about Assam, let us be, concentrating on Assam only now. Now, comparing Assam with the rest of the states, so far the statistics are concerned, will not be very wise because Assam is very different than other states in geography, history, social values, and other cultural differences. If you cannot compare the health indexes only on the basis of statistics, because for example 20% of the population in Assam is from tea garden. So if you minus the health statistics of garden, then you will see the rest of the Assam is very comparable with the rest of the country. So far women are concerned, women health is concerned, health is not something which has to be provided by only medical professionals, or making medical doctors available will improve the health instantly. That is also not possible. And modern medicine itself has failed. In 80% of the world population, there is no access to the modern medicine. Only 20% of the population is. getting access to the modern medicine. Because the 80% of the population needs the basic amenities in the form of sanitation, water, drinking water. If all these things are done, I think they don't need medical care. So this modern medicine practice itself has to be again redefined if we really want to change the statistics and on the ground if we want to see the change. Because more and more doctors are coming out, but somewhere things have failed because, for example, when somebody gets pregnant, we take it as a patient. That itself is a very wrong concept. A pregnant mother is a physiological process. She needs more care and advice than brilliant prescriptions. But again, in our society, they are taken as a patient, let them go to a doctor, and the doctor has to have a healing touch, and he has to write a prescription, and she will be, improving all the parameters that make her a better female or a healthy female to deliver a healthy child, which will become a healthy citizen. So these are some of the issues where, for example, this care, as I said now the care can be provided better to a pregnant mother. The care can be provided by a good midwifery nurse, good dietitian, good psychologist, rather than a MD in obstetrics and gynecology. So we will have more number of people to give the service even at the rural level if this point is stressed to the mind of the people that a normal pregnant mother needs good advice, good nutrition, good care, and good psychological counseling, good education, rather than going to we wait for a doctor to come and give advices. This will help us in a big way if we really want to improve the rural women health system. And that is definitely is going to happen because now more and more nursing colleges are coming. The only thing is the role of the nursings are not very well defined in our nursing council. Whereas in European and other countries, the nursing roles are very well defined. Now a GNM nurse is also a nurse, a BSc nurse is also a nurse, a MSc in midwifery is also a nurse, a PhD in midwifery is also a nurse. Now, if this PhD in midwifery can be in charge of the whole area where the pregnant mothers or the women are getting pregnant, the care can be taken in a more better way if their roles are defined and they are given responsibilities of taking the care of the mothers.
Now I come to Dr. Monisha Behel. You have worked for a long time on this issue. Dr. Behel, maybe you do agree with me that children and women will continue to bear a disproportionate burden of pandemic. So where are we failing in this regards, especially in the context of women's access to health?
I think it has already been articulated quite well. I've been working at the grassroots from 1978, but of course my development work started in the 80s. I was with the Tezpur Jila Mohila Committee. From there, I went into Start Northeast Network. It's a women's organization with a very liberal feminist perspective. And the one thing that I saw was that we have a wonderful infrastructure from the government. Even now with the Assam government, there are more and more hospitals coming up. But, excuse me for saying this, but jiman ami fieldot goisu, ami himan dekhisu, je PHC, primary, prothom hoise sub-center. Koru karbar ghorot sub-center eta thake. Okay? Tar pisot ahe etu PHC, primary health center. Primary health center, dorob ase, doctor ahe, everything. Then you have to have this health and wellness program. Jiman ami research korisu ba survey korisu, ami tat dekhisu je doctor normally nahe. I agree with you what you are saying, that it's the women themselves, the pregnant women themselves, who need to look after that. So, but that is the human resource side. So I'm just telling you about the infrastructure that Ohomot, মই সেইদিনাখন গোলাঘাটলৈ গৈছিলোঁ, তাত চাউৰা বস্তি বুলি এটা জেগা আছে, তাত বহুত দিনৰ পৰা এটা চাব চেণ্টাৰ আছে, পিছে তেনেকৈ কাম কৰা নাই। তাৰপিছত বৰভূঞা গাঁও এখন আছে, তাতো মানে দেখিছোঁ PHC আছে, পিছে ডাক্তৰে কোৱাৰ্টাৰত নাথাকে, তেওঁ অইন ঠাইৰ পৰা আহে। So when this happens, a lot of people get very, very disillusioned, and then they are also starting to take loans. তাহাঁতি property বেছি দিয়ে, বা তাহাঁতি loan লৈ পেলাই প্ৰাইভেটলৈ যাবগৈ খোজে। So this is a sort of a dichotomy that we have, but I would, as a social worker, as a person who has put in many, many years, I really believe that, আমাৰ কোনোটো বুৰ্বক নহয়, সবৰে এভাৰেজ ব্ৰেইন এটা আছে, সবে জানে যে আজি পেটটো বিষালে মানিমুনিটো ল'ব লাগে, সবে জানে যে লিভাৰটো বেয়া হ'লে শিলিখা লৈ পেলাই তই খাব পাৰ, এনেকুৱা এটা কথা আছেতো। I would think there has to be a sort of a movement where গাঁৱৰ মানুহৰ পৰা আৰু আৰ্বান ল'ৰা ছোৱালীও এইবোৰ কথা জানিব লাগে, and we have to, আমি প্ৰচাৰ কৰিব লাগে যে হাৰ্বেল মেডিচিনটোৱে কি কৰে, প্ৰিভেনশ্যন কৰে, কিয়ৰ নকৰিব পাৰে, প্ৰিভেনশ্যন কৰে। দেন কামছ দ্য নিউট্ৰিশ্যনেল ফুড। যোন চব বস্তু দিল্লীত এতিয়া মই দেখিছোঁ, শাক পাচলি, সেইটো অসমত বহুত বেছি গুণৰ মানে বস্তু আছে, যোনটো খুব স্বাস্থ্যৱান বুলি মই ভাবিব পাৰোঁ। এণ্ড আই থিংক দোজ আৰ নিউট্ৰিচিয়াছ, এণ্ড আই থিংক দেৰ হেজ টু বি চাম নলেজ, চাম লোকেল নলেজ হেজ টু বি propagated amongst village people once again to talk about what nutrition values are. And in this we have to think about activists. When I say activists, I mean whether they are students or whether they are people from Mahila committees or from the panchayat. Everybody should be able to give a little bit of their human value to the village. Etia moi dekhisu, I'm sorry I'm extending, a lot of people like to go to the city. And মই তাহাঁতক ব্লেম নকৰোঁ, আমিওতো গুৱাহাটীত থাকোঁ, আমিওতো তেজপুৰত থাকোঁ, আমিওতো দিল্লীত আহি পেলাই পঢ়িছোঁ, মা দেউতাহঁতে ইয়ালৈ পঠিয়াইছে, কৈছে বোলে এডুকেশ্যনটো বেছি ভাল হ'ব পাৰে। ঠিক তেনেকৈ গাঁৱৰ ল'ৰা ছোৱালীওতো বাহিৰত যাব খোজে। চ' উই কেনট ফল্ট দেম ফৰ দেট, বাট হোৱাট উই শ্বুড ব্ৰিং বেক, বিকজ দেৰ আৰ নাও শ্বিফ্টছ ইন দ্য, দেৰ ইজ আ ক্লাইমেট চেঞ্জ গোয়িং অন। We have to depend more on our own agriculture. We have to depend on our own farming methods, our indigenous seeds sharing. Seeds jetia hoy, indigenous seeds. Ami keneke he seedsbur ekeloge cooperate kori eta district or itu district lege exchange koribo paru jate there is food security, number one. There is knowledge amongst young people and also people, teacher fraternity too, about how we can address this food security so that nutritional standards can come up. And lastly, with the government of Assam, I know that Mrs. Ajanta Neog has put in about 3,800 plus crores for the health services of Assam. But nothing can work till we people who are the frontline workers, Anganwadi workers, ICDS workers, still we have the will to go and work in the villages. No, বহুতে ঘিণ কৰে যে মই সেই কাৰ্বি গাঁওখনলৈ নাযাওঁ, তাত মানুহবোৰ এনেকুৱা, মই এইটো গাঁৱলৈ নাযাওঁ, মানুহবোৰ তেনেকুৱা। So I think a new system has to come up, and I'll be willing to talk to anybody about it, of bringing up a young generation of people who can instill in the minds of urban ল'ৰা ছোৱালীs, urban children and youngsters, to understand the value of human life at the rural level.
Thank you, Dr. Monisa Behel. Madhulika, you have, as you are from UNICEF, your goal is to, save children, protect their rights, right? And you have worked in all over the Northeast region. So Dr. Monisa Behel already told about we have the highest density of tribes in Northeast. So different tribes, they have different culture, different beliefs. Some beliefs are not so good also. Some are brilliant, So these beliefs and customs and rituals, sometimes, what is your experience? Sometimes in malnutrition and these challenges, they also, these things also, influence.
Yes.
Do you believe like that? And what your challenges when you approach that area?
No, thank you for that question. When we talk about the Northeast, so we're talking Assam and other Northeast states, and we're talking about the ethnic diversity. I always feel, and this is also what UNICEF celebrates. We celebrate children and women, and this diversity is to be celebrated. And we need to go back to this diversity, this ethnic diversity, the linguistic diversity, the diversity in the food grain, the diversity in their local practices. And when we talk about malnutrition, because you talk about malnutrition both for children and I would say even women, these are important connections to be made where we talk about food grain which is locally sourced, because that is what is most comfortable and most easily available to a mother or to a caregiver in a rural setting, in a village, in a community. Having said that, we also realize that gender plays a very important role in malnutrition. And that is either coming from a rural context or from an urban context. We also realize that there are, I would say, inequalities in the rates of malnutrition among boys and girls. And a lot of work has been done. So, you know, the supplementary nutrition that is given in the Anganwadi or the hot cooked meal at the school. So these things exist. But how can we, you know, make these more accessible to children, especially when we talk about the Northeast states, where it is difficult to have, with a very low population density, to have the same criteria for an Anganwadi as the plains. And though the criteria are different, the infrastructure, the training of the workers, the training of the ASHA, the training of the Anganwadi workers. So it's contextualized. It is not a module that comes from anywhere else, and then they are following something which doesn't make sense to their people. The participation of self-help groups, the participation of the Panchayati Raj institutions is very critical to, I would say, eradicate malnutrition, because I think that has been also a very important message that has come from the government of India, the Poshan Ma, which really talks about this time's Poshan Ma in September. It really spoke about Mahila and Swasth. It talked about Bacha and Siksha. So, and that is common, that is a common thread. But how do we contextualize it for the Northeast? How do we contextualize it for Manipur? What works in Manipur may not be exactly working in Arunachal. It may not work exactly in Meghalaya. It may be similar, but it cannot be the same. It should not be the same. The cost of services, say in Guwahati, of reaching a child, or even say Kamrup, rural, we talk rural, cannot be the same as reaching someone in Namsai. It cannot be the same as reaching someone in Ribhoy. And that differential planning and differential costing, the whole thing of bringing that fiscal understanding to children's rights and children's programs will be very critical. It is very critical to make that change. So while we celebrate diversity and ethnicity, the basis of it, which is the program, the financial space, the understanding, the program structures, those must also be agile. They must continue to be able to contextualize themselves to the need of the people and the communities. I think that is the critical space.
Dr. Sharma, you just told about that our population pattern, 20% of our population is tea community. Hey, অঞ্চলবিলাকক লগাই পেলাই ডেটাবোৰ সেইকাৰণে হৈছে বুলি আপুনি কৈছে। এতিয়া কথা হৈছে কি সেইখিনি মানুহক অন্তৰ্ভুক্ত আমি কৰিব লাগিব। গতিকে সেই টি কমিউনিটিয়ে হওক বা স্পাৰ্সলি পপুলেটেড আমাৰ ট্ৰাইবছ এৰিয়া, এই গোটেইবিলাক সামৰিবৰ কাৰণে আপুনি ভাবেনে যে আমাৰ ইনফ্ৰাষ্ট্ৰাকচাৰ ইজ অল ৰাইট ফৰ দিছ টু কাভাৰ অল দিছ কমিউনিটিজ? আৰু কিবা আপুনি যে ক'লে যে আপোনাৰ নাৰ্ছৰ কথা, ডক্টৰ কথা, এইখিনি কম হয় নেকি? আচলতে আমাৰ মেন পাৱাৰটো কম নেকি ঢুকি পাবৰ কাৰণে? নহ'লে কিয় যে আমাৰ যে আপুনি টি কমিউনিটিৰ কথা ক'লে, তাতে আপোনাৰ ৰিপিটেড তেনেকুৱা কমিউনিটিবিলাকত not only in tea community, all communities, who are not so much aware of all these things, modernization, they cannot, they are not aware of all these things. They repeated childbirth and the space between childbirth. It's a very major factor of pregnancy, right? So to make them aware, what your suggestion to do?
On a side note, actually, I practice in Guwahati, and the problem I face with the mother is not undernutrition, the overnutrition is the problem. So obesity is a big problem for women and adolescent girls now. which leads to hormonal disorders and all the chronic diseases, which makes her a very high risk pregnant mother in the form of diabetes and hypertension. So I would like to say the stress we give on undernutrition, now the overnutrition is also a big global problem which is going to happen.
But percentage is, I think, very less, right?
No, in urban population too it is
Comparing
very high.
to our population.
No, in urban population I am saying
Yeah,
it is very
okay.
high. Now when we come to rural population, as you said, about the places where the medical facility is not up to the mark, how can we improve the maternal and child mortality or health?
True.
So as she said, you can't be very generalized when you plan a program for a population. You have to take into consideration the different problems of different population. It cannot be a generalized, a linear mathematics that you start a program which is applicable to all in the same way. For example, when you are thinking about the garden problems, it cannot be the same of a rural village problem. The rural village of Assam, they have a long history of Ayurveda. And while they take food, they have been for last 3-4 generations have been taught by their grandfather and these are good things. Lasun khale, blood pressure bhal hoy. Tar pisot apuni hak khale, etu bhal hoy. So these are some of the values which we have started neglecting by going to the quick fix doctors. So the rural population which had good habits has gone into bad by traveling on the weekends to the urban areas and trying to get glamorized by what glamour they see, and they come back, oh, I should have gone to the hepatic surgeon or hepatic liver specialist who will give me a tablet of garlic which is for atherosclerosis or hypertension. But the ingredient of a garlic can only work when the garlic comes in the mouth and you chew it, and the liquid which comes from the garlic which interacts with the saliva, then one antioxidant and anti-atherosclerotic material will be released. The moment you mask that by a tablet, the activity of that ingredient is gone. So we had good things in our history in the rural villages, which we are trying to, making it poorer by coating them with quick fix medicines. So that is one thing which should be educated and prevented. Now, having said that, if we come to the garden, now garden is you have to take totally in the garden into a picture from the economics point of view. You can't, now there may be forces who do not want them to be well educated, well healthy, and they should have good progressive mind. Maybe that is harmful for the business they are doing. So this is one very important point which we do not consider when we talk about this. I have seen tea gardens where the males are alcoholics. The more the males are alcoholics, the female will go for plugging. And the more they work for the whole house and they have many children, they will neglect their health. So this cycle has to be broken. Now to break the cycle, we have to take the society as a responsible. Only government schemes, government cannot do everything. The society has to supplement the government, and then only I think the things can change. For example, there are gardens, suppose there are gardens, 4, 5, 6, 10 gardens near Jorhat, 50 gardens near Guwahati. Now there are so many private hospitals which can be incorporated into the scheme where they can send their doctors weekly to the garden, where the garden clinics are without doctors for long years. This can be only happen when you recognize the services of the privates also. If you take them into as a workforce, now if they are also recognized, then I think in totality you can find a solution of improving the number of human resources, and we can really do good in improving their nutrition, and talk to the garden owner about it, who must be made accountable of the health of the workers, whom they pay their salary every weekly or monthly. There can be a simple screening program of hemoglobin checkup, which doesn't cost much. Now, if this is made accountable by the garden owner who makes his fortune out of the work of those workers, then only things will start changing. And here the private medical players, the nearby hospitals who have a social responsibility can be encouraged to participate in this program and get recognition by the government on their services will help in a big way.
Thank you. One garden owner was there, but I think he left now. Dr. Monisa Behel, আমি যিমানখিনিলৈ এতিয়া কথা পাতিলোঁ যে এই গোটেই ইনফ্ৰাষ্ট্ৰাকচাৰটোৰ কাৰণে পইচা লাগিব, সেইটো একদম মেইন ৰিজন ইজ ডেট যে আমাৰ ফাণ্ডটো লাগে এইটো কাৰণে। এতিয়া গভৰ্ণমেণ্টে অকলে কৰিব নোৱাৰে, আমাৰ এৱাৰনেছ লাগিব। আপুনি ভাবেনে যে মানে what is the role of corporates? They have now big funds, as a CSR like that. So don't you think that they could help in this thing?
Sorry. First thing, I don't entirely agree with you that we need many more funds in order to get this health infrastructure up. Because, as far as Assam is concerned, I think the infrastructure is there. The systems are there. I mean, all kinds of schemes have come up about nutrition, about midday meals and all. The defect I'm seeing is about quality care, the quality. And it boils down to attitudinal. If in a home, amar ghorar bhitorot jodi patriarchal ketaman values loi pelai horu swali jonik neglect kore, tamane apnaluke bhabok je eta hospitalot jot doctors ase, jot patients ahe, ekdom big crowds of women come to get treated. The attitudinal behavior is not there. So that has to shift. So I know money is required and this is required. Now, what I want to say is that funding, I'll talk about funding because we have had funding from all over from the world. We have got funding from the government of India. We have got funding from CSR also. I want to say that from the policy side of the government, we have big policies. CSR is ready to use 2% of their profits or their turnover for NGOs. And I know that comes to crores. ONGC is a typical example. They have given crores and crores of rupees to many NGOs, even to the metros and things like that. Now, their whole thing is about addressing environment. More on environment and more on the business. And whatever they do, they would want something in return. So when I ask a CSR, health or karne mok etu lagibo, then he goes, no, mokso he jaga tu khub garam, thik ase ami 1000 fan di dib, pise amak report lagibo je apni 1000 fan paise aru hetu solito obosthat apni film ekhon lobo laibo. So different corporates have different attitudes, but I think as of now the issue of environment has come. They say intelligently we can use the issue of health, and I'll tell you how. Because with COVID, juntu kando hol India, where health infrastructure, tea garden women, pregnant women, everybody was in a very bad way. There were strained relationships domestically. There was a lot of domestic violence. I mean, nije chief secretary usole go apply kolu je jeta lockdown samoy hoise 108 kam kora nai etu karone apni kibata korok, and he very kindly, Jisnu Borua, he brought in the 108 and ordered that any woman who is having this problem, especially in the areas of Jorhat and tea garden areas, he was able to get these people brought in and given shelter. So number one, we have to collaborate with the corporates about these issues. We have to collaborate with the government. And when there are problems like this, like the COVID, let me tell you that COVID might come again. Let me tell you that floods will come again and again. Let me tell you that with urban spaces coming up, Guwahati has become a jungle, unplanned. There'll be more and more floods, even if the Brahmaputra is next to you. There's no way of channeling anything. So there's going to be a lot of problems. So we need to collaborate. We need to have the goodwill to work together. And I would really recommend that the governments of the northeast states, Assam, Mizoram, everywhere, they have to look into, I'm not saying it because I belong to an NGO, but you know, there has to be an attitudinal change with civil society organizations. আমি civil society organizationত কাম কৰোঁ। মই জানো কোভিডৰ সময়ত আমি 50 lakhs উঠাই পেলাই ক'ত দিছোঁ, even to the forest guards of Balipara side. You see? So we need to collaborate, and I think that's the only thing I will say. Thank you.
Thank you. Madhulika, how is your experience with working with young people? Because mostly we are talking about the age below 5 years, children and pregnant women. But how about the young people? Are they very aware of this, or how is your experience working with them?
When we in UNICEF, when we talk about young people, we're talking adolescents 10 to 18 and young people till 24, 15 to 24. So young people really are the future of our country, and our hopes are really sort of pinned on you, especially the young people present here. Our experience with young people, I mean, we've had various partnerships with youth teams. Worked very closely with NSS in the Northeast and worked very, very strongly, especially during COVID times, where a lot of awareness and a lot of support was garnered through the NSS. And when we look at young people, I think that is the sort of the investment that we are making in young people, making them aware of deprivations that children and other young people have, whether it is being undernourished, whether it's not being healthy, being anemic, whether not being in school, whether facing violence, whether being just married as a child. Also, this awareness is something that will really help to create more energy within the system. When we talk about various social protection schemes, especially when we were discussing also about the tea gardens, we work, as UNICEF, we work in 205 tea gardens with the Assam branch of India Tea Association and the Bharatiya Chai Parishad. So we work collaboratively with these associations with about 30,000 adolescents in the tea gardens. And one thing that the power of adolescents is that we started with about 30% girls being married about 10 years ago. So this is 10 years ago. Married before the legal age, it was 18 then. And over a decade, with the support of young people, with the awareness that they have received, the training and the capacity building that they have received, today in the 205 tea gardens, the survey that we have done, that has come down to about 2%. In COVID, these numbers did increase. So I agree with Monisha ji that COVID was difficult for everyone. Yet there is a power with young people where they are able to convince other young people as peers. And taking again to the point that our previous panelists spoke about, actually mentoring others. So as peer leaders, they are able to influence other young people's aspirations, the kind of struggles that they are going through. So that is one thing. This is really the demographic dividend that we want to also invest. When we are looking at various schemes, we looked at the Sirish portal, we looked at various scholarship that young people could get. Now going away a little bit from the tea gardens to Bodoland, where the situation is different, the experience of young people has been conflict-ridden, and the need of the hour really is peace building and social cohesion. The dropout rate from school is very high, because the schools are very far away and young girls would not want to cycle through a forest to a school. And that is the effort that the government is now making, where they are actually building more schools, bringing them closer to habitations, and investing in young people so that both through education and sport, which was discussed previously as well, to see how they can build communities which are more cohesive. So whether the Rabha and the Bodo young people can grow together, can have aspirations that take them together. I just want to make one point, especially about the work that UNICEF does. The principle of our work really is equity and gender. Those are the underlying threads of our work. And when we talk about equity, we know that there are forest areas which are, I would say, not in the, which are not proper revenue villages. And so often young people do not get services there. And we are hoping that with the government, with the Bodoland team, we will actually be able to reach all these young people and children. The other area is gender, where again the gender disparity, not only for Assam indicators, but also in Northeast, where Manisha ji talks about patriarchy and where the access to education is very limited. The other point that is very important here is the Northeast being the most climate vulnerable part of the country. The importance of risk-informed programming is also very critical. What we build today gets washed off next year and we build again. We may build better, but we end up building again. And that is another area of resilient planning. Young people actually coming forward to be the resilient soldiers or the resilient young people of the future who will actually help us to understand resilient communities and how communities can continue to function and communities can continue to safeguard their children, women and young people. I think that would be very important.
Thank you, Madhulika, for nice explanation. And Dr. Sharma, though you say that, data always doesn't portray the real picture, still this data, infant mortality rate, maternal mortality rate, and this data we got from the, National Family Health Survey. So this data disturbs us. So as I'm not a medical person, I just want to know from you, is the reason maybe the climate or genetic or the lack of infrastructure?
Let us come to the infrastructure. So as you see, we have seen in last 8 to 10 years, the government has really done laudable improvement in the infrastructure. So for tertiary care, medical care is concerned. Now at the primary level, as I said you, the primary level, for example, when I was a medical student, then when we used to be posted in the gynae department, obstetrics department, the number of neglected obstetric cases in the form of obstructed labor, cord prolapse, pre-eclampsia, eclampsia, there were plenty of cases we used to get at night. But before coming to this conclave, I asked my friends who are working in different medical colleges, and I don't have exact data, but I have asked them whether the new students, new doctors are also getting the same number of cases. Then it was absolutely no. They said nowadays we don't get this type of cases, very rarely we get. So that is another, if the periphery is not improved, then you will definitely get more number of cases. That speaks that in the periphery or in the civil hospitals, the things have improved and people know when to go to for deliveries, go to the institution, healthcare facilities should be taken, and the neglected home delivery where the quacks used to do delivery has gone down. So this is number one. Number two is, as I said you, that if you really want to improve the healthcare right from the adolescent to the pregnant mother, so that a healthy infant is born who becomes a healthy citizen, then education is a must. You cannot separate education from the health. And the education is not only to the children or adolescent girls, the parents are to be educated. Now the biggest challenge is the education of the parents. This is one area I think where a big role has to be played by entrusting the people whose children are in the garden workers, the importance of the education. And from the garden, the children who have become really good, they have become good doctors, good IS officers, good police officers. Now if these people are portrayed as model in the garden, maybe the garden parents will be encouraged that if he can become like this, why not my children? And these are some of the initiatives which, if taken, and education and health is really taken as a holistic approach in improving the health of the garden people or chore areas, then the statistics will definitely improve and the government is working on this with the help of mobile clinics
Yeah,
in the
true.
garden, then the boat clinics in the chore areas, and things are really improving. Only thing is the more and more stakeholders in this field are to be incorporated so that more workforce is there, and the lack of workforce do not become responsible for not improving the rate of the healthcare in a better direction in the future to come.
Mani Mohan, thank you. Thank everybody. There are not is there are many.
No question.
There are many actually.
Many.
I will not allow so many, but let's go to Priyambada Kashyap, Jamia Millia Islamia. Are you there in the hall?
Hello, a very good afternoon to all of you present here. This is an open question for all the panelists. So, since we're talking about healthcare in general as well, so there is something that happens quite frequently in the healthcare system when women's symptoms are not taken that seriously, be it chronic pain or reproductive issues. And this is also something that is called medical gaslighting in some sense. So, what can we do about it at a systemic level?
Can you, Dr. Madhulika, will you pick it up?
Madhulika?
And thank you. It's a very interesting question, and I think very true, very real question. I think this really goes back. One is access to healthcare. So when it's come to reproductive health of women, access to care at a very community level, when we talk about primary health care and universal health coverage, I think that is the need of the hour, and that is where more and more frontline workers need to be able to address this. The second point is when we are looking at what Dr. Sharma spoke about, tertiary care, and how with the Ayushman Bharat card, whether that has really become accessible to women, especially from the rural areas, because tertiary care is difficult and expensive, and how can we really reach that? I think that is the question that we need to answer for ourselves.
Niborna Hazarika, a PhD scholar from JNU, are you there in the hall?
So my first question is, we all know the condition of women during the menstruation period in Assam and also in other parts of the country. Women are treated as untouchables by their own family members specifically and also by the women at large. Do you think carrying this forward is relevant considering some scientific perspectives, or you think it's high time we stop these baseless norms of the society?
I'll give a very short answer again. Menstruation is something that everybody knows about, and you're right that people are secluded and kept separately. Things have changed a lot because CSR has got into a big way about menstrual sanitary napkins and all. But the good news is also that corporates are starting to support a lot of civil society organizations of making disposable and reusable sanitary napkins. And there are good examples in Northeast. We have two in Tezpur, we have one in Meghalaya. And what we do is, because we are not scientifically equipped to talk about this so much, we use them to start training of trainers. Once the village women get trained of how to manufacture this, how to dispose it and things like that, then the business starts. They start producing it, simple method ase, and then they sell them, and this is how an income comes. This is how the superstition about menstruation goes, and this is how it becomes most hygienic, because the healthcare then comes into the play. This is what I want to say.
Next is again to Monisha Bahel from Rajashree Pathak.
So, ma'am, my question to you is that having my ancestral root from
Having your
having my ancestral root from a village in Assam, I have witnessed villagers taking treatment from so-called untrained doctors known as veg, popularly.
known as bears.
Yes.
Yeah.
And I have heard of instances where the treatments fail and it leads to the deterioration of the health of the sick person. And my question to you is that, despite having a good infrastructure, as said by politicians in the rural sector, how do you think we can tackle certain instances, such popularity of veg and such other people, with reference to women's health?
I couldn't hear much, but
With
I've got the idea.
Role of veg.
There are two things I want to say. Now it's 2022. I remember 1970s and 80s, we had the dhai system. Dhai to gusi gol agote. Our base system is also gone, but we have, please make a differentiation between scientific people who have worked on herbal medicine. When you look at that, then you have Dabur and all working on it. But a Bez is somebody who can also get into a bit of shamanism, who can do bhute jari se, bhute lagi se, etu bahut kiba kibi superstition ase. So I think we have to make a difference within that. But today, if I talk about 2022 and I talk to young people about it, I think there are many opportunities to learn the more scientific and practical way of dealing with issues of women and disease and hygiene. Just like I talked to you about the menstruation. About 15 years back, I don't remember even one young person saying that, look, moi etia sanitary napkins bonabo janu, itu eneke bonai, but it has come up. So I think there's always a beginning, and I'm sure there'll be people who can be trained. But in this, I want to say that I hope the government of Assam, and sorry, but excuse me, but I hope Protidin, which is a media house, a lot of media houses do many things. I wonder if we could all have a dialogue about how a generation of young people can be given an opportunity through these media houses, because you have more opportunities of getting CSR fund, or how we can train young people about this issue of nutrition, about issue of giving opportunities for digital education and things like that.
Thank you. And this is a very interesting question about women's mental health from Sibanki Raskwa, JNU. Sibanki, are you there? Yeah.
Hello, panelist. My question is, when women's issues are being taken up, the stress is more upon her physiology. There is not enough emphasis and awareness upon her mental health. A lot of women face serious mental health issues during menstruation, reproduction, postpartum, menopause, which are being approached with denial and negligence. So how do we start focusing on women's mental health as a serious issue while talking about women's health in general? Thank you.
I think the biggest solution to women's mental health is actually talking about it and saying that it's okay to be not okay. And when we talk about mental health, one thing that really we have experienced as UNICEF is mental health and psychosocial support, which we did a lot of that with young people, with teachers, some parents, but mostly teachers and children during COVID. And this has become a very strong thread through our child protection program, where we realize that mental health then is a very important pillar to results in the sectors that we want results in. And that is something that will be, which will strengthen the work. So one is speaking about it, being able to access it. In Assam, the government has worked with NIMHANS, which is the Bangalore-based National Institute, to create these mental health points. Happy to talk more about it.
Quick intervention from Pramod Sharma before I wrap up the session. Sanjada also had something about board clinics. Sanjada, I have to now.
The young lady was talking about mental health. If you take brain, there is something called neurology is a science, but mind is not a science.
Exactly.
Mind is not the allopathic science. So for mental health, it is not that you have some disease in your brain or some lesion in your brain or something because of which you need a medical care about it. The counseling part, self-counseling, and tranquils the mind, and yoga is one of the best answer. So it has worked well, and a lot of research studies have said that postpartum psychosis or adolescent some abnormalities which happens in the behavior. So yoga plays a very big role, and you can read about this and can practice in your life.
সবকে ধন্যবাদ জনাইছোঁ আৰু বিশেষকৈ ধন্যবাদ জনাইছোঁ এইকাৰণে যে আগতে যেতিয়া এনেকুৱা মানে ছেশ্যনবিলাক কৰোঁ তেতিয়া কি হয় যে যেতিয়াই ওমেন ইছ্যুজবিলাক আহে হলত মানুহ নাথাকে ওলাই যায় ওমেন ইছ্যুজ খালী হল বহুত মোৰ এনেকুৱা অভিজ্ঞতা আছে কিন্তু আজি যে এইটো সেশনত এই গোটেই মানুহখিনিয়ে সহযোগ কৰিছে মই বিশেষকৈ ধন্যবাদ জনাইছোঁ চবকে